Welcome to the ASSURE platform. As we have already put a small intro video on what is ASSURE and what we are doing, I'll just like to brief again. So ASSURE Educational Foundation has been doing need-based classes in DM, and now we have started in the super specialty for surgery and general surgery with super specialty. So there are various branches that we are covering. Surgical enterology, gastroenterology, and hepatobiliary surgery is being covered by me and my team. And we have surgical oncology, pediatric surgery, CTVS, and urology and neurosurgery. So, as a part of the surgical gastroenterology and hepatobiliary team, Dr. Prithiviraj, I'm leading the team. I did my MS from PGI Chandigarh and did my MCH from GB Pam Delhi. After that, I went to Paul Booth in Paris and I did my fellow in liver surgery and transplant. Now I am a consultant GI and HPB surgery in Madurai. So, and apart from me, the team members include Dr. Pradeep, who is right now in Adayar. He is also a PJ, MS from PJ, an MCH from AIMS, and we have Dr. Soundar Rajan. He is also MS from PJ and MCH from MMC. So we have 2 or 3 more people who are joining us for the further classes. So we're split into organ-based specific topics, and this is a mock class so that you can get an idea of what and how we go about. So basically, we wanted to make this an interaction-based teaching rather than giving just facts or just letting you mugging up MCQs. So straight away, because this is a MCQ-based platform, these questions, so we'll just straight away go into.
Shivani.
So we'll just go into few questions.
ఫోన్ చేస్తానని చెప్పింది నాకైతే.
I think I'll
వదిలేస్తున్నా అని చెప్పింది.
Dr. Srinivas Reddy, can you?
నాకు ఇంకా చెప్పలేదని చెప్పినా.
Can you just mute yourself, Srinivas Reddy?
నిన్ననే చెప్పినాను కదా.
అంటే నాకు వదిలేస్తున్నట్టు చెప్పలేదు కదా.
Dr. Srinivas Reddy, can you just mute yourself? Okay, I just put him on mute. So let's go for the discussion. So, question. Segmentation. Can the host please put him in?
No, you are the host. You have to put them on mute now.
Okay, I put him on mute. Then who?
There is one more new person now. Yes, okay.
Okay. Now this is fine, right? Okay. So, coming to the question, true about liver segmentation is. So, what are the options? Right portal caesura is in the frontal plane in a craniocaudal position. The umbilical fissure contains the left portal caesura. The left portal caesura is anterior to the ligamentum teres. And the left medial section is composed of only one segment, that is segment 4. So we get these types of questions, which is very deeper in the anatomy, and they are taken from every line of Bloomgart or Shackelford. So if you can, you just guess your answer and keep it, and we'll go into the discussion and finally come out with the answer. So as you know, the segments of liver, it is divided into 8 segments, and you can see this. It is mainly based on the Coinoid and Healy-Schroff classification. So this has been later changed by the Brisbane terminology. So it is basically based on the hepatic veins, we can say, the right hepatic vein, the middle hepatic vein, and the left hepatic vein. The middle hepatic vein lies in the central fissure, and that divides the liver into the left and right sections. And further subsegmental branches can be divided, and this has been mentioned as sectors by Quenon. So the right liver has 5, 6, 7, 8, which is clockwise, and the left liver has 2, 3, 4. So if you see, it is mentioned in the clockwise direction. And the segment 1, that is the dorsal part, it is in the posterior aspect, and there is a small diagram that you will have to remember. You have to close your fist, and your closed fist will help you identify the segments. So if you close your fist, your thumb will be the caudate lobe, and the first index and the middle finger will be the 2, 3, and 4, and the other two fingers will be the 5, 6, and 7, and 8. So in the Brisbane terminology, it has been divided as right and left lobes. And in the right, it is an anterior and posterior section, whereas in the left, it is a medial and lateral section. That this is very important. So this will form the basis of the liver anatomy, because if you see in a live patient, actually the segment of 6 and 7 goes posterior and the 5 and 8 comes anterior. So it is actually rotated. So actually we are derotating the anatomy and when we are reading. So when we rotate the anatomy, it is like the entire 6 and 7, it goes in the posterior plane, and when you're supine, it is in a frontal plane. That is what we see. The 6 and 7 is down, and the 5 and 8 is up. And this Brisbane terminology, there has been a lot of questions regarding this. And when we come to this, if you see that the left medial section, it consists of only one segment, that is segment 4 of the quinoid. So left medial sectionectomy that means it is removal of only 4. In the left lateral sectionectomy, it's also called, it's a bisegmentectomy, where the segment 2 and segment 3 are removed. And if you see the right trisectionectomy and the left trisectionectomy, they include only the lobes of, like if it is a right trisectomy, it is the right lobe along with 4, and the left it is sectional left appendectomy. It is 2, 3, 4 with 5 and 8. So the caudate lobe has not been included in this, but usually when we do a hilar cholangiocarcinoma, the caudate lobe is also taken with this. So just I mentioned, this is how it looks like in a patient anatomy, the real anatomy, where the segment 5 and 8 are above and 6 and 7. So this right portal fissura is in a frontal plane in the supine position. And see, this is the umbilical fissure, and actually the portal vein comes and just joins the umbilical fissure after the segment 4. So the umbilical fissure does not contain the left portal fissura, but it contains only the branches to the segment 2 and the segment 3. So if you can see, this is the bile duct and this is a portal left portal system that is coming. The segment 4 branches come as in a retrograde fashion like this, but the hepatic veins supply it is in a upper plane rather than in the umbilical fissure. So this is a shortened, simplified diagram. You can see the main scissura, the right scissura and the left scissura. And usually the portal vein divides the lobes into the upper lobe and just consider as the upper lobe and middle lobe. So between 2 and 3, there is portal vein. Between 4A and 4B, there is portal vein. Between 5 and 8 and between 6 and 7, there is a portal pedicle. So this is of importance. And the left medial section is composed of only one segment, that is segment 4. The important point to note is that you have to see what it is mentioned. If it is a section, then it means Brisbane terminology. If it is a sector, it may be either quinoid or heliostrop, but usually heliostrop is not commonly used. So if they put it as a sector, then you will have to consider as the quinoid segments. But nowadays the quinoid segment has gone into vogue, and mostly the Brisbane terminology is being used. So coming to the question, so what is true? The right portal fissure is in the frontal plane in the craniocaudal position. No, it is actually in the supine position, as we said, when the patient is lying down. The umbilical fissure contains, no, it does not contain the left portal scissura. The left portal scissura is anterior to the ligamentum teres. No, actually the left portal scissura is posterior. Like if you can see, it should be like here the umbilical fissure comes here, and the portal pedicle is posterior to the ligamentum teres. This is the ligamentum teres. The falciform ligament continues as the ligamentum teres, and this continues behind as the ligamentum venosum. And a part of it which is separating the caudate lobe, we call it as the arranchius ligament. So all these 4 are in continuation: the falciform ligament, the round ligament, the ligamentum venosum, and in the fissure of ligamentum venosum lies the arranchius ligament. So the correct answer will be left medial section is composed of only one segment. So going to the next question. Caudate lobe. True about drainage, all except. The caudate lobe is one of the difficult topics because it is very difficult. It is a difficult thing to grasp visually because it is sandwiched between the IVC and the other lobes. So the question is true about drainage or all except. That is, see, every question you'll have to read properly because it is true, all except. That means which is false. So left side portal supply is almost exclusively from the left portal vein. Right portion is supplied by the right anterior sectional artery. The veins drain into the posterior aspect of vena cava, and in 78 of patients, the bile duct drains into both systems. So you will have to find out which are all true and only one of it is false. So questions like this will be tricky because you may know maybe two answers which are true, but one you may not be knowing correctly. So that's why the in-depth knowledge of these things is required, and that's where we are here to help you out. So if you can see this is a picture. This is the common picture that is you usually see in Savistton and Shackleton. So this is the IVC, this is the portal pedicle, and usually the caudate lobe is sandwiched between these two. So this is the main process of the caudate lobe, which usually initially we call it the spigal lobe, and this is the caudate process. And sometimes there is a right portion, and the demarcation is not that perfectly identified. So this part is brown, and this is green, and this is yellow. Okay. In segment, this portion, the right portion is sometimes mentioned as segment 9 of the caudate lobe. That is right portion of caudate lobe. But this has been taken off since 2002, and we don't use this terminology now. So the left side of portal supply is almost exclusively from the left portal vein, and right side it may be from the right side or even from the left side. But if you see here, this is the branch coming from the left portal vein. Right may be supplied both by the left or the right portal vein, and the right portion is usually supplied by the right posterior sectional artery and the posterior sectional duct. If you see in the anatomy, because the posterior sectional artery it lies more horizontally, and the posterior and the anterior sectional artery lies vertically. So the posterior section is actually horizontal, and it supplies the right portion of the caudate lobe. And there is a tricky point in this question because veins drain into the posterior aspect of vena cava. Actually, veins from the posterior part of the caudate lobe drain into the vena cava that is there, and that drain into the anterior aspect of the vena cava. So, are there any veins that drain into the posterior aspect of vena cava? Yes, it can happen because 50% of the patients with caval ligament, they have a replaced liver tissue. So, if you see here, this will be like there will be this is actually cut higher above. So when you go down, you will see a caval ligament, and sometimes 50% of the patients it is replaced by a liver tissue. So whenever there is liver tissue, there it is bound to have a drainage into the nearest part of IVC, that is in the posterior aspect. So this is partially correct. The veins draining into the posterior aspect of vena cava is also partially correct. And regarding the ductal drainage system, 78 of patients have drained into both ducts. In 15 patients, it's only into the left ductal system, and in 7%, it is only into the right ductal system. So, coming to the next question. So, I have selected a few questions which are tricky, and this has been given in fewer exams before. So, coming to the next question, the subvesical duct. So, all are false except. So, what is a subvesical duct? It is usually found beneath the gallbladder, and it is not the duct of Luschka, we know. Because duct of Luschka is entirely different from the subvesical duct, and we have to be clear about that. So, all are false except. That is, only one is true. So, this is present in 15 to 20% of cases. Usually drain a part of segment 5. Never communicates with the gallbladder. Injury occurs if the thick plate is not preserved. So, coming to the question. Okay. So, coming to the bile duct. Just a minute. Coming to the bile duct divides into the right and left hepatic ducts, as you know. The right divides into right anterior and right posterior. And the right posterior is located to the left of the right anterior sectional branch. This is very important. The right posterior duct is located to the left anterior sectional branch of portal vein. So that's why we come with the portal vein first, and then the duct comes behind there. On the left divides into segment 2, 3, and 4. They are all located above the corresponding portal vein branches, except that the right posterior is located a little into the left of the right anterior sectional branch. And coming to the subvesical duct, all are false except it is present in 15 to 20% of cases. No, it is present in 20 to 50% of cases. Usually drain part of segment 5. No, it doesn't drain any specific liver territory. Never communicates with the gallbladder. It's correct. And injury occurs with the, I'm sorry, this must have been cystic plate is preserved. So injury occurs if the cystic plate is not preserved. So if the cystic plate is preserved, then the injury does not occur, and this does not drain any part of the liver. It is considered to be a remnant of portal vein. Okay. So if you come to the anatomy of the bile duct, so if you see the right, usually the right and anterior and posterior join together and they join with the left hepatic vein, and this is commonly seen in 57% of the patients. In 20%, there is a alteration in the right anterior. See, actually, what is the hilum is defined as where near the liver tissue, the formation of bile duct, a discernible bile duct, that is called the hilum. So 20% there is a variation in the right anterior. So in 16%, the right anterior goes down below and joins beyond the confluence of the right posterior and the left hepatic duct. In a few patients, the right posterior is joined later, and the right anterior forms the confluence. So in 6%, there is a change in the alteration in the right posterior hepatic duct, and other minor variations are very few, and we need not mug up these numbers. So further, there are some more variations. We just need to know that what is the common thing that happens, and the other variations might not be asked that commonly. So the right anterior is formed by segment 5 and segment 8. It goes straight up, and the right posterior is formed by segment 6 and segment 7 that rise in a supine plane. So one is goes up and one horizontally. And usually they are like bifurcations from each other. Sometimes few variations are also found, and these variations are important whenever we do a segmentectomy or a posterior sectionectomy sort of cases. And even the segment in the left side, usually the segment 2 and 3 they join, they form a duct, and in the umbilical fissure the segment 4 joins. So sometimes there might be two branches of the segment 4, or it may join into the segment 3 and drain directly into the bile duct. So another question: aberrant right hepatic artery is a branch up. See, these questions are called like sitters because the moment you see, you know the answer. The problem is 80 to 90% of the people also know the answer. So the main thing of reading questions like this is that you should not commit mistake in this, because you are going to have a very big disadvantage if because this is one of the toughest branches to crack, and if you're going to miss out in these simple facts, then it will become difficult. So most of you might know the answer. The aberrant right hepatic artery is a branch of. So coming to the hepatic artery, it is as you know, it is arising from the celiac axis, the common hepatic artery, and it gives rises to the right and left hepatic. So the common hepatic artery usually arises from the celiac trunk in more than 80% of the cases. In 10%, there is an absent common hepatic artery. So the right hepatic artery, as we know, it originates from the proper hepatic artery in 80%. So they replace right hepatic arteries from the superior mesenteric artery in 15 to 20% of cases. And the axillary right hepatic artery also usually arises from the superior mesenteric artery in 5%. Directly arising right hepatic artery from the aorta has been just documented in very few cases. So you can confidently say that the aberrant right hepatic artery usually arises from the superior mesenteric artery, and that will be our answer. The right hepatic artery, after the arising, it goes underneath the common hepatic duct in 65% and the common bile duct in 10% of cases, and it is anterior to the common hepatic duct in 10% of cases. That is where we say we should not injure during a cholecystectomy. And coming to the left hepatic artery, see all these numbers are 80, 80, 18, and you can remember this. So this is the value from Shackelford. The left hepatic artery arises from the hepatic artery proper in 80% of cases. And replaced left hepatic artery, it can arise from anything that is near. You can see the left gastric artery or the celiac axis, or from a replaced common hepatic artery in 15 to 20% of cases. And axial left hepatic artery is seen in up to 35% of the individuals. So coming to the next question, liver blood flow. The false statement is. So the hepatic artery normally supplies about 25% of total liver blood flow and provides 50% of oxygen requirement. It supplies at a rate of 30 ml per minute per 100 gram of liver tissue. It provides exclusive blood supply to the intrahepatic bile duct through the peribiliary plexus. Complete long-term dearterialization of the liver by any form of arterial vascular occlusion is not very difficult to achieve. So usually questions like this will be a tricky one, and if you do not know the answer, it is better not to answer, because this might give you a false thing, that hope that you may get it in a fluke, and most of the time the fluke answer is a wrong answer. So let's see the liver blood flow. So the blood flow, the total liver blood flow is 800 to 1200 ml per minute, and it is almost like 100 ml per 100 gram of tissue, 100 to 100. Okay. So it is 25% of the cardiac output, and then out of the body's total oxygen consumption, it takes 20% of the total oxygen consumption. In the hepatic artery, it is like 25% of the total blood flow to the liver is from the hepatic artery. It's a high pressure, high resistance system, and the approximate value is 30 ml per minute per 100 gram of liver tissue, but it provides up to 50% of the oxygen requirement of the liver, and it is an exclusive blood supply to the bile duct through the peribiliary plexus. So this you might all know. And there are extrahepatic collaterals and intrahepatic collaterals. So this is of significance because extrahepatic collaterals, it comes from the phrenic artery, adrenal artery, and other arteries that goes through the triangular ligament and other barrier area of the liver. Actually, barrier area, there are very few named arteries. Sometimes there are some few branches, but the most common collaterals we think of are the phrenic and the adrenals. So coming to the intrahepatic collaterals, there are a few unnamed collaterals that cross from the left to right, and they are named as interlobular artery. And there has been an artery that has been shown frequently that is crossing in the hilar plate, that is from the left hepatic artery to the right hepatic artery, or vice versa. And that's why we say that even if you divide the right hepatic artery, we have to preserve the hilar plate so that the intrahepatic collaterals will take care of the blood flow to the other side of the liver. Usually that's what happens. Even in the right hepatic artery ligation, that is usually below the hilar plate, we don't see that total necrosis type of thing, because it is taken care of both by the intrahepatic and extrahepatic collaterals. And that is why complete dearterialization of the liver is not possible, because you'll have to tie up everything at the same go. If not, if you tie one branch from the right hepatic artery, then the phrenic and the adrenal will enlarge. If you tie the phrenic, the adrenal and the intrahepatic collaterals will enlarge. So complete dearterialization long term is not possible to achieve. So coming to the next, portal vein, 25% from the hepatic artery and 75% from the portal liver blood flows from the portal vein. So it is like 90 ml per minute per 100 gram of the liver tissue, and it provides 50 to 70% of oxygen requirement. And the hepatic veins, usually the pressure range is like 1 of pressure, and the pressure gradient is in the range of 5 millimeter of mercury. In all the other systems in the body, usually the arterial system ends and the venous system arises, and if you measure the pressure gradient, it is usually very high. But this is one of the places where the pressure gradient is very low, and that is the peculiarity of the liver. So coming to the question, just a minute. So the answer is, false statement is, the complete long-term dearterization of liver by any form of arterial vascular occlusion is actually difficult to achieve. And the other three options are correct. So coming to the next question, liver intrinsic blood flow regulation. So sorry, this is not a question. I have just put a small slide on the liver intrinsic blood flow regulation, and this is like Every point has been asked as a question. And the hepatic artery buffer response is one of the most commonly asked question. And it is actually a compensatory flow change in the hepatic artery at pre-sinusoidal level. The flow increases up to 30% from the baseline on portal vein flow reduction. It is usually adenosine mediated, and it is capable of buffering 25% to 60% of portal flow. The hepatic artery constricts with increased portal flow, but the vice versa does not occur. This is the usual point they give that the vice versa occurs, but usually the vice versa does not occur. And there is no change in the portal flow with response to the hepatic artery, decreased flow or occlusion. So the hepatic inflow is not controlled by liver intrinsic metabolic needs. So in all the other systems, if you suppose take a muscle or everything, increased activity will cause increased blood flow. But in liver, the hepatic inflow is not controlled by the intrinsic metabolic needs. And the other concept you will have to know about is the intrahepatic vascular resistance. And it is usually mediated by the hepatic stellate cells and sinusoidal endothelial cells. And the one thing you'll have to remember, there are so many mediators there that has been tried, like nitric oxide and others, angiotensin and everything, but only hydrogen sulfide has been shown to have a direct role in vivo models. So that's it. These are the few questions that we have discussed. So I would like to tell you that this will be the type of questions that will make a change in your preparation. And reading line by line is not that feasible, and that too covering entire Shackelford and Bloomgart. So this is like a synopsis of whatever that has been given in Bloomgart and Shackelford. So this is just an introductory class, and further detailed sections will be taken according to the class schedule. So if there is any questions, I am ready to take questions. And you can even give suggestions. So please unmute yourself and you can ask any question if you have. Or you can put it in the chat box.
There is one question on the chat box.
Okay.
What is the difference between cystohepatic duct and duct of Lushka?
The cystohepatic duct and duct of Lushka are the same, but the subvesical duct is different. It's actually cystohepatic. Okay. That is communicating from the gallbladder into the liver. That is the cystohepatic duct of Lushka. Subvesical duct is actually a duct that doesn't even contain bile.
So we also have Dr. Pradeep from the surgical gastro team. There is one more question.
How to find segments if CECT is given? Actually, this is an entirely different topic for the radiological segment. So I'll just give you a clue. You just identify the portal vein. You just decide if it is above the portal vein, the cuts, or if it is below the portal vein. So the cranial segments are 2, 4A, 8, and 7. And the segments below the portal vein are usually the other like 3, 4B, 5, and 6. So the portal vein decides. So on caudate lobe, like it is, you can easily identify with the help of IVC. And other landmarks that is useful is this is like mainly first you have to identify the portal vein, next you have to identify the hepatic veins. So from a single cut, it is usually not able to, you cannot find out easily. But if you locate the hepatic vein, then you can divide like what I said in the main liver is divided in left and right by the middle hepatic vein. You have to locate the left hepatic vein or the right hepatic vein, and thereby decide the right anterior, posterior, or the left medial and lateral. By this, you can identify the segments. Usually the gallbladder is also in a fixed position, and you can say that segment 4B and 5 are in relation to the gallbladder. Which is this structure that divides the liver into segments. So it is usually actually the portal pedicle. Liver is divided into sections and segments. You will have to remember, because sections are like right and left, right anterior and posterior section, and the left medial and lateral section. The further divided into segments by the portal pedicle. Usually the portal pedicle resides the liver segments. Yeah, unmute yourself and ask, because I do not know if I have cleared your doubt. You just go ahead and ask as if it's a direct class, because even I might be wrong. So if you have a suggestion, you can say. I already told you, like we things are given as will be as given as fact sheets, so that you can go through it in the last minute preparation also. Making your own notes will also be useful, because uh, you keep on reading and you cannot take the book every time and read the entire chapter. Is there any question, or we can conclude the session? I don't understand this question. Valiant predicted. Is this a question? I'll have to find out. I think sheath is the answer, but I'll have to find out. I'll get back to you with the answer in the next class. Sometimes questions are even taken from the pictures and the diagrams, so it becomes difficult to answer even if you have read it very nicely. You can contact us in the NEET super specialty link that we have given in the Telegram group, so that everyone will be benefited by the doubts you ask. Because your doubts, maybe the other person might have the same doubt, or even if they don't have the doubt, maybe they will understand better.
So if there are no other questions, I think we will wind up this session. So please join the Telegram group, which I have put it in the chat box. So we are also planning for a mock test, which will be, the date will be announced in the Telegram group itself once we conclude the model classes. So just keep a watch on the group, and you are free to ask your doubts to the surgical gastro team, and whatever doubts you have, we will answer. Anything else?
I think that's fine. We can wind up the session.
Okay.
Okay. Thank you.
Okay. Thanks.